Okay, let us start. Our today's topic is the same what we started last time. It is about phonocardiogram. So that is listening of heart sounds. Okay. So I will repeat the video what I have shown you last time. Then I will go to the PowerPoint presentation.
As S1 is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow as it passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated. Heart murmurs are whooshing sounds produced by turbulent flow of blood. Murmurs are diagnosed based on the time they occur in the cardiac cycle, their changes in intensity over time, and the auscultation site where they are best heard. Examples of conditions associated with common systolic murmurs include mitral valve regurgitation, when the mitral valve does not close properly and blood surges back to the left atrium during systole. The murmur starts at S1 when the AV valves close and maintains the same intensity for the entire duration of systole. This hollow systolic murmur is best heard at the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through a narrow opening. The blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular border. Aortic valve stenosis.
I will repeat this part here. Please focus on what is mitral regurgitation and tricuspid regurgitation and aortic stenosis, because in our PPT also we will see this. So let us focus on what is mitral regurgitation, as I told, and tricuspid regurgitation. I will repeat it again.
When the aortic valve does not open properly and blood is forced through a narrow opening. The blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve. Aortic stenosis murmur is loudest in the aortic area, and the sound radiates to the carotid arteries in the neck following the direction of blood flow. Again, on the other side of the heart, a pulmonic stenosis has the same characteristics but is best heard in the pulmonic area and does not radiate to the neck. Other conditions that cause audible systolic murmurs include ventricular septal defect and mitral valve prolapse. An example of diastolic murmurs is aortic valve regurgitation. This is when the aortic valve does not close properly, resulting in blood flowing back to the left ventricle during diastole, the filling phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area.
So what is being discussed here, it is aortic regurgitation. So in this case, the valve does not close properly, and that's why the blood flows in the reverse direction. So just listen again.
The aortic valve does not close properly, resulting in blood flowing back to the left ventricle during diastole, the filling phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area but rather along the left sternal border. It peaks at the beginning of diastole when the pressure difference is highest, then rapidly decreases as the equilibrium is reached. Other common diastolic murmurs are associated with pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a
In this video I'm going to be going through heart murmurs. You can find written notes on this topic at zerotofinals.com or in the cardiology section of the Zero to Finals Medicine book. Let's jump straight in. First of all, we need to talk about the normal heart sounds, and we refer to these as S1 and S2. The first heart sound, or S1, is caused by the closing of the atrioventricular valves.
So what is being discussed, it is, I also told you earlier, S1 and S2, these are the normal heart sounds. So later on in our PPT, we will see there are two more sounds heard called as S3 and S4. So those reasons also we will discuss later. So let us go ahead.
Now this is the tricuspid and the mitral valve. And this happens at the start of systolic contraction of the ventricles. So as the ventricles try to push blood out of the heart, the valves between the atria and the ventricles need to close to prevent blood from flowing back into the atria. The second heart sound, or S2, is caused by the closing of the semilunar valves, and this is the pulmonary and the aortic valves, once the systolic contraction is complete, and this is to prevent blood flowing back from the pulmonary arteries or the aorta into the ventricles. Now this S1 and S2 can be heard during auscultation of the heart sounds as a lub-dub sound. So let's have a listen to that now. Next, let's move on to a third heart sound, and we call this S3. And this is heard roughly 0.1 seconds after the second heart sound. It's quite subtle, so you can only just about hear an extra sound after the second heart sound. Let's listen to an example. Now what causes this sound is, I think of it as rapid ventricular filling, causing the chordae tendineae, or the tendons inside the heart, to pull to their full length and twang like a guitar string. This can be normal in young patients, 15 to 40 years old, because the heart functions so well that the ventricles easily and rapidly fill with blood. But in older patients it can indicate heart failure, as the ventricles and the chordae are stiff and weak, so they reach their limit much quicker than normal. The way I picture this is, an older patient bending over and their tight hamstrings very quickly and sharply tightening as they reach the limit of their flexibility. This often sounds a bit like lub-de-dub, lub-de-dub. So let's have a listen again to what that sounds like and see whether you can distinguish a third heart sound after the second heart sound. Next, let's talk about the fourth heart sound, and we call this S4, and this is heard directly before S1. And S4 is always abnormal, and it's relatively rare to hear. What this indicates is a really stiff or hypertrophic ventricle, and the sound is caused by turbulent flow from an atria that's contracting against a ventricle that is non-compliant or doesn't want to fill with blood. So the ventricle is really stiff, the atria is trying to force blood in, and this is causing a turbulent flow. And what it sounds like is lub-dub. So let's have a listen and see if you can distinguish that fourth heart sound just before the first one. Now let's talk about heart murmurs. So when you're listening to murmurs, you want to auscultate with the bell of your stethoscope to hear low-pitched sounds, and the diaphragm of your stethoscope to hear high-pitched sounds. And you can think of this as a child's high-pitched scream from their diaphragm, or a church bell giving a deep bong. You want to listen over the 4 different valve areas in turn for murmurs. So the pulmonary area is at the second intercostal space on the left sternal border. The aortic area is on the second intercostal space on the right sternal border. The tricuspid area is in the 5th intercostal space on the left sternal border. And the mitral area is on the 5th intercostal space in the mid-clavicular line, and this is the apex area. You can also listen at what's called Erb's point, and this is the 3rd intercostal space on the left sternal border, and this is the best place for listening to the heart sounds, so S1, S2, S3 and S4. There's a couple of special maneuvers you can use to look extra clever in your OSCEs. This would be to put the patient on the left-hand side, or roll them over onto their left-hand side to listen to mitral stenosis. Or you can sit the patient up, lean them forward, and ask them to take a deep breath out and hold, and this helps you to hear aortic regurgitation. There's a few features of a murmur that you can assess, and we use a mnemonic called script. So S is for sight, meaning where is the murmur loudest. C is for character, so is it soft, blowing, crescendo, meaning getting louder, decrescendo, meaning getting quieter, or crescendo decrescendo, meaning getting louder and then quieter. R is for radiation, so can you hear this murmur going to the carotids, as you would in aortic stenosis, or going to the left axilla, as you would in mitral regurgitation. I is for intensity, so what grade is the murmur? P is for pitch, is it high-pitched or is it low and grumbling? And pitch basically indicates the velocity of the murmur. And then finally T is for timing, so is it systolic or diastolic? So I'll go through that mnemonic again. Script, meaning sight, character, radiation, intensity, pitch and timing. Let's talk about the grade of murmurs. So grading a murmur is quite subjective, but it can be helpful in assessing the severity of the defect, and it will also make you sound clever when you grade a murmur in your OSCEs. If in doubt, it's probably grade 2 or 3. So grade 1 is difficult to hear, grade 2 is quiet, grade 3 is easy to hear, grade 4 is easy to hear and with a palpable thrill, so when you put your hand on the chest you can feel the murmur. Grade 5 is when you can hear the murmur with your stethoscope barely touching their chest. And grade 6 is when you can hear the murmur with your stethoscope actually off the chest, just holding it nearby. Let's talk about hypertrophy and dilatation of the heart. Valvular heart disease can cause hypertrophy, which is where the heart muscle thickens outwards and into the chamber of the heart, or it can lead to dilatation, which is where the heart muscle gets thinner and expands. Think of it blowing up like a balloon. And this happens in different heart areas depending on where the pathology is. When the heart muscle is pushing against a stenotic valve, it has to work a lot harder to try to get the blood to go through that valve. So this results in hypertrophy. So if you have mitral stenosis, the left atrium is pushing really hard against that mitral valve, so you get left atrial hypertrophy. When you have aortic stenosis, that left ventricle is pushing really hard against that aortic valve. So
stenosis means it is a narrowing of that valve or the vein or artery. So here it is being said that aortic stenosis, that means aorta becomes very narrow, and that's why blood is being forced with more force.
End up with left ventricular hypertrophy. When you have a leaky valve that allows blood to flow back into the chamber, it stretches the muscle and results in dilatation. So when you have mitral regurgitation, there's blood flowing back through the mitral valve into the left atrium, so you end up with left atrial dilatation. When you have aortic regurgitation, there's blood flowing back from the aorta into the left ventricle.
The meaning of this word regurgitation is the backflow, which is not actually normal. Okay, so that is regurgitation.
So you end up with left ventricular dilatation. Let's talk about our first murmur. So we'll start with mitral stenosis, and this is where the mitral valve becomes narrowed and makes it difficult for the left atrium to push blood through to the ventricle.
So the mitral valve becomes narrow, and that is called as mitral stenosis. So since the valve becomes narrow, it becomes difficult to force the blood, and that produces some sound called as a murmur.
It's caused by two things, rheumatic heart disease and infective endocarditis, and it causes a mid-diastolic, low-pitched rumbling murmur due to the low velocity of the blood flow. Because the blood is flowing through such a narrow area, it flows only very slowly and rumbles its way through. You also get a loud S1 due to the thick valves that require a large systolic force to shut. Once the systolic force reaches a certain threshold, the valve shuts very suddenly. So what you end up with is this loud lub and then a dub dur. So let's have a listen to it. So did you catch that loud first heart sound, and then that second heart sound followed by that durr rumbling murmur? Let's have one more listen. A few other features of mitral stenosis is that you'll be able to palpate a tapping apex beat due to the loud S1, and it's also associated with a malar flush. This is a flushing of the patient's cheeks due to back pressure of blood into the pulmonary system, causing a rise in CO2 and vasodilation. It's also quite commonly associated with atrial fibrillation, and this is due to the left atrium struggling to push blood through a stenotic valve and causing disruption to the electrical signals and resulting fibrillation of the atria. The next murmur to talk about is mitral regurgitation. Mitral regurgitation is when an incompetent mitral valve allows blood to flow back through during systolic contraction of the left ventricle. And because during systole there's blood flowing backwards through this valve, you end up with something called a pansystolic murmur, meaning the murmur is present throughout the systolic period. And it causes a high-pitched whistling murmur due to the high velocity of blood flow through the leaky valve. This murmur sounds a bit like brr, brr, because it happens the entire way through systole. Let's have a listen. You can hear that the murmur is present throughout the whole of systole between S1 and S2, and this is what we call a pansystolic murmur. Let's have a listen one more time. When you hear this murmur, listen at the axilla because it tends to radiate to the left axilla. It's also associated with congestive cardiac failure because the leaking valve causes a reduced ejection fraction and causes a backlog of blood that is waiting to pass through the left side of the heart. Therefore, you might also hear a third heart sound when listening to this murmur if there's heart failure present. So what causes mitral regurgitation? Well, the most common cause is idiopathic weakening of the valve with age. So as a patient ages, their valve just naturally gets a bit weaker. It can also be associated with ischemic heart disease, infective endocarditis, rheumatic heart disease, or connective tissue disorders such as Ehlers-Danlos syndrome or Marfan syndrome. Next, let's talk about aortic stenosis. So aortic stenosis is probably the most common valve disease that you'll encounter. It essentially means a narrow aortic valve, and so as blood flows through this narrow aortic valve during systolic contraction, there will be turbulence of blood flow. So this causes an ejection systolic murmur, and this is a murmur that occurs while blood is being ejected from the left ventricle, and it's a high-pitched murmur because of the high velocity of systolic contraction. It's also what we call a crescendo-decrescendo murmur, as it gets louder and then quieter due to the speed of blood flow during the different times of systolic contraction. So you'll hear the first heart sound and the second heart sound, and then between those heart sounds you'll hear a systolic murmur that gets louder and then quieter. It causes a murmur that sounds a bit like burr-dub. See if you can hear it. There's a few other signs that you'll find in a patient with aortic stenosis. The murmur will radiate up to the carotids as the turbulence continues up into the neck. So you can put your stethoscope over the carotid arteries and listen for a murmur there. It's also associated with a slow rising pulse and a narrow pulse pressure. So when you palpate the pulse, it will be slow to rise, and when you do the blood pressure, the systolic and diastolic pressure will be quite close to each other. Patients with aortic stenosis also have symptoms of exertional syncope. This is lightheadedness and fainting when exercising, and this is due to difficulty maintaining good flow of blood to the brain through that narrow valve. The most common cause of aortic stenosis is just idiopathic age-related calcification of that valve. It's just the valve becoming older with age and calcifying, becoming hardened and narrowed. It can also be caused by rheumatic heart disease. The final murmur that we're going to talk about is aortic regurgitation. Aortic regurgitation is basically where the aortic valve becomes incompetent and blood is able to flow back from the aorta into the left ventricle. Because blood flow back through this valve will happen during diastole, aortic regurgitation causes an early diastolic and quite a soft murmur. So it sounds a bit like lub-tar. See if you can hear it on this example. Don't worry if you can't hear it, it's a really subtle murmur that even cardiologists can miss. So have another listen, just see if you can hear it after the second heart sound, a gentle, soft, early diastolic murmur. Aortic regurgitation is associated with something called Corrigan's pulse, and a Corrigan's pulse, which is also called a collapsing pulse, is when it rapidly appears and then disappears as the blood is pumped out of the ventricles and then immediately starts flowing back through the aortic valve into the ventricles. Aortic regurgitation often results in heart failure, and this is due to the back pressure of blood waiting to get through the left-hand side of the heart. It can also cause something called an Austin-Flint murmur, and this is worth knowing about just for your exams. It's heard at the apex and is an early diastolic rumbling murmur, and this is caused by blood flowing back through the aortic valve and over the mitral valve, causing the mitral valve leaflets to vibrate. This is very difficult to hear in real life. Aortic regurgitation is caused again by idiopathic age-related weakness, but it's also worth remembering that it can be caused by connective tissue disorders, such as Ehlers-Danlos syndrome or Marfan syndrome, where patients with these conditions have difficulty in creating strong connective tissues, leading to weakness of the valve leaflets. So thanks for watching. I hope you found this video helpful. If you did, don't forget there's plenty of other resources.
Now I am sharing my PowerPoint presentation, so we'll discuss all these points what you just saw in this videos. Okay, so it is phonocardiography called as PCG, or it is nothing but listening about heart sounds. Okay, so what do you mean by auscultation? So auscultation is actually listening our heart sounds, not actually heart, whatever sounds are generated by our body. So listening those sounds, that science is called as auscultation. And auscultation area is the area at which this sound is captured. So that is auscultation area. Phonocardiography, it is one of that which is particularly listening to heart sounds. So these sounds are produced by vibrations set up in the blood inside the heart by the sudden closure of the valves, movement of the heart valve, closure of heart valves, and turbulence and leakage of blood flow. So that is what we have seen in the last two videos what you watched. So these sounds are produced because of the sudden closure of the valves, because of movement of the heart valve and closure of the valves, and the corresponding turbulence and leakage of blood flow. So this leakage causes murmurs. These are all different types of sounds what you see in this diagram. So there are different cases actually, A, B, C, D, E and F. So A, so the sounds represented by this waveform A, these are in the normal patients. So first one, this is S1, the second one is S2, and very rarely here S3 and S4 are observed, and after this point this is again start of the next cycle. Then the second case, case B, this is the patient having aortic stenosis. Stenosis means it is the narrowing of the aortic valve. Okay, then when there is mitral regurgitation. So as we have seen earlier, regurgitation, it is the reverse flow of the blood, which is again not normal. Similarly, aortic regurgitation, mitral stenosis, when the mitral valve it becomes narrows down, that's why more force is required for the blood. So that is the case of mitral stenosis. Then patent ductus arteriosus. So this is some disease related to heart, right? So based on these different types of sound waves, the doctors will analyze whether the patient's heart is breathing normally or there is some problem in that. Okay, so first heart sound, that is lub, so that is also denoted as S1. So this is due to the closure of mitral and tricuspid valves, which permit the flow of blood from atria into the ventricles. It occurs at the end of the atrial contraction and at beginning of the ventricular contraction, and its duration is about 0.05 second after the onset of QRS complex. So QRS complex we have seen earlier, this is one of the peak in the ECG waveform, which occurs just before ventricular systole. So it has a loud deep pitch, and the frequency of this sound, it is 30 to 45 Hertz. And it is greater in intensity than the second sound, and the duration is about 50 to 100 millisecond. Auscultatory area, that means the area around which it can be heard, it is best heard at the apex of mid pericardium. So pericardium, it is the outer layer of the heart, and it is heard at the apex means the tip of the heart. So at the apex of mid pericardium. Then the second heart sound, called as S2, it occurs at the end of ventricular systole, and it causes due to closure of semilunar valves in the arteries leading out of the ventricles. It occurs 0.03 to 0.05 in second after the end of T wave in case of ECG. And the pitch is higher than the first sound, and it is 50 to 70 Hertz. The duration is 25 to 50 millisecond. And the auscultation area, that means it is best heard in the aortic and pulmonary areas. Then the correlation of this ECG with heart sounds. So here what you see, the ECG waveform, and related to the ECG waveform, the S1 and S2 are shown here. So as we have seen earlier, the S1 occurs at the end of this QRS complex, and similarly S2 occurs at the end of T wave. So the first heart sound, it is produced immediately after QRS wave, after the rise of, it is at the rise of intraventricular pressure causes AV valves to close. So that is the reason for producing this first heart sound. Second heart sound produced after T wave begins. So that is what you can see here. So after the T wave begins, you can see the second heart sound. Then the third heart sound, it is due to the cessation of ventricular filling. It is heard in children and patient with left ventricular failure. So this is not actually the normal heart sound. Due to the left ventricular failure, due to rapid inflow of blood from atria into the ventricles, the accumulated blood from atria and veins causes the distension and vibration of the ventricles, and because of that this sound is heard. Frequency is below 30 Hertz. Duration is 0.1 to 0.2 second, and it starts 0.12 to 0.18 seconds after the second heart sound. And the auscultatory area, it is best heard at the apex and left lateral position after the lifting of the legs. Then there is fourth heart sound. This is also not the norm in the normal condition, and it causes by contraction of the atria. It is not audible due to the low amplitude and frequency of vibrations. It occurs immediately before the first heart sound, and it starts 0.12 to 0.18 seconds after the onset of P wave. Duration is 0.03 to 0.06 second, and frequency is 10 to 50 hertz. So this is about the fourth heart sound. Third and fourth heart sounds are called diastolic sounds and are generally inaudible in the normal adult, but are commonly heard among children. Now, what are the applications of listening these heart sounds? They provide indication of heart rate and its rhythmicity, whether the beating of the heart it is in the rhythmic manner or not. They also give useful information regarding effectiveness of blood pumping and valve action. So the heart sound, it will give whether the pumping action of the heart and the valves are working properly. Then we have seen in the earlier videos there are some sounds called as the murmurs. So these murmurs also, these are not the normal sounds. So it occurs in abnormal hearts between normal heart sounds. They are higher pitched sounds in the frequency range of 100 to 600 range and are longer in duration compared to normal heart sounds. Causes of murmurs are, actually these causes of murmurs we already saw in the earlier videos. So let us discuss those things. Let us write down systematically. So the causes of murmurs are high velocity blood flow that occurs through small opening when there is improper opening of the valves. So when there is an improper opening of the valves, these murmurs occur. It also occurs because of regurgitation. Now regurgitation means the backward flow of blood, and which is not a normal case, not in normal heart. Okay, so which results when the valves do not close completely and allow some backward flow of the blood. So this gives rise to some sounds called as murmurs. Sometimes in some people with some heart problems, there is a small opening in the septum. Now septum is the partition between the auricle and the ventricle, so that separates the left and right side of the heart. So this forces blood through the opening from the left ventricle into the right ventricle, bypassing the systematic circulation, and this is actually the problem. So because of some small hole in the septum, the blood will flow from left part of the heart to the right part of the heart, which is not a normal condition, and it causes some sound called as murmurs. Okay, now difference between the heart sound and the murmurs. Heart sound, it is transient in character and are of shorter duration. These are of low frequency. Mainly the causes are mainly due to closing and opening of the valves, whereas murmurs are noisy and higher pitched sounds and of longer duration and has high frequency 100 to 600 hertz, and it is due to the turbulent flow of blood in the heart and large vessels. Now let us become familiar with some more terminology related to the sounds. Vibrocardiograph. Now this is the sound related to vibrations produced by the side of the heart as it thumps on the chest wall. So as the heart is continuously beeping, it produces some sound when it thumps against the chest wall. So that sound it is called as vibrocardiogram. Then apex cardiogram. So this is produced when the tip of the heart hits the rib cage. So that is apex cardiogram. Then pulse. We are familiar with this. Pulse, it is felt with the fingertips at certain points on major arteries which approach the surface of the body. That we call it as the pulse rate. Then ballistocardiogram. So it is the recording of motions of the body due to the beating of the heart and the corresponding blood ejection into major arteries. So because of the beating of the heart and the blood ejection into the major arteries when the pumping action of the heart is taking place, so this produces some sounds, and that is called as ballistocardiogram. Okay. Now how these heart sounds are measured? We are familiar with this acoustic stethoscope which doctors normally use. There is an electronic stethoscope available, but this electronic stethoscope, doctors do not prefer it. It is very rarely used. This acoustic stethoscope, it is a very ancient technique which is being used till now. Then phonocardiography. So phonocardiography is the science of plotting the sounds. So that's why it is called as graphy. Phono means sound, cardio means related to heart, and graphy means plotting that. This is the typical block diagram of phonocardiography. There is a condenser microphone, which transducer which converts sound into some electrical signal. Then phono amplifier. There is a filter to process this sound wave, and the monitor or the scope. Then there are ECG electrodes, ECG amplifier, FM tape recorder. So typical block diagram of a phonocardiography. These are the points where usually the microphones are kept while plotting these sounds. That means the phonocardiogram. Applications of PCG, that is phonocardiogram: detection of rheumatic valvular lesions, so detection of heart diseases; detection of aortic stenosis, that means if the aorta gets narrowed, we have seen earlier, if the aorta becomes narrow, more force is required for the heart to pump the blood, and it produces murmur, sound called as murmur. Then to detect murmur of mitral regurgitation, if the mitral wall, if there is a reverse blood flow through the mitral wall, that means if it does not close properly, then there will be backward flow of blood, and that results in the murmur. So it can be detected. Then murmur of aortic regurgitation, again the backward flow of blood if the aortic wall does not close properly. Murmur of mitral stenosis, if the mitral wall does not close properly, mitral wall becomes narrow, more force is required for the heart to pump the blood, it produces the murmur. Special applications of PCG, it is for recording fetal PCG during pregnancy. Then esophageal PCG, to listen various sounds in our esophagus, that means in Marathi we call it as Anna Nalika. Then tracheal PCG, so this is related to our air pipe which is connected to the lung, so that sound can be heard for diagnosis purpose. So these are applications of PCG. So this is all about the phonocardiogram, called as the heart sounds and murmurs, their causes and applications. Okay. So if you have any questions, you can ask.